That is interpreting urine microscopy. It will be done by Dr. Kailas, and diagnostic approach to proteinuria by Dr. Binu, and evaluation of hematuria by Dr. Jitesh. And I think these topics will be very useful to you. Now, coming to my welcoming part, on behalf of Kerala FPA Midzone, I would like to President Dr. Danya to the CME. And today also I'm really very happy to welcome all the alumni of Lourdes Hospital, Dr. Kailas and Dr. Jitesh, and speakers also, and Dr. Binu, our Chief Nephrologist, Lourdes Hospital. I would also like to appreciate the committee members and their efforts for preparing for this event today. And once again, I welcome you all, and thanks for taking time out and to be here with us today. Now I request Dr. Danya to give the presidential address. Jisha, Danya unmute.
Hello, Kekamo. Good evening. Good evening, everyone. And once again, I'd like to congratulate AFPA Kerala Midzone for conducting a webinar. And very happy to see Binu sir after a long time. Today we have our mentor and the alumni of Lourdes Hospital all together giving a talk. And even though it seems to be a simple topic, but very important for all of us. So without taking much of time, I'd like to hand over the venue to the speakers. Over to you, Dr. Indu.
Thank you, Dr. Danya. Now, Dr. Rashmi is the chairperson for today. So I request Dr. Rashmi to introduce the speaker. Dr. Rashmi, as you all know, she's the HOD of Family Medicine, Department of Family Medicine, Lourdes Hospital. She's also the AFPA India Treasurer. Dr. Rashmi, over to you. Kindly in Kailas.
Good evening. As you said, it's all a Lourdes show, I think. Starting from the first alumnus of family medicine in Lourdes till now, and Binu sir. So I'm extremely proud, and I don't know, words cannot express my pride in introducing the first speaker, my student, Dr. Kailas, who has done DNB from Lourdes Hospital, MNAMS and BCCPM, that is palliative care, and his special interests include diabetology, palliative care, and geriatrics. Presently, he's working as assistant surgeon in Kerala Government Health Services as a COVID warrior. He has won the best paper presentation at the second National Conference of Family Medicine and Primary Care held at New Delhi in 2015. He was also part of the third prize winning team of quiz competition held at Wonka SAR conference at Chennai in 2014. He was also awarded the Young Doctor Award at 4th National Conference of Family Medicine held at Bangalore. At present, he holds the position of FM 360 Coordinator, Spice Route India. So welcoming Kailas with pride and happiness. Over to you, Kailas, for your topic.
Thank you, madam, for the kind words. And it is indeed a great pleasure for me to be speaking in front of all this my teachers, my mentors, after a long time. So without much delay, I would like to start my topic, and I thank the AFPA Kerala Midzone for giving me this opportunity to talk. I'm just going to deal about urine microscopy. We all might have seen during our regular routine practice that we will send urine routine, and the results come as there will be some cells, cast crystals, and here and out return like that. So here we are going to look at what all things that we are seeing from the result, and how should we interpret these things. So what is urine microscopy? Urine microscopy is defined as, it can be said as also a liquid biopsy of the urinary tract. The urine contains small microscopic sediment particles that settles on standing. Such small particles are called as urine sediments, and these can be classified into organized substances or unorganized substances. So, how a specimen should be collected for a urine microscope? A midstream, freshly voided first morning sample is preferred because an acidic, hypertonic urine, all the elements are well preserved. And also the specimen should be examined within 2 hours of voiding, because on long standing in room temperature, most of the elements may get will be gone. And if preservative is needed, 1 crystal of thymol or 1 drop of formalin, 40% is to be added to 10 ml of urine. So how are we going to do the test? First of all, you have to centrifuge for 5 minutes. At centrifuge the urine for 5 minutes at 1500 rpm, and the supernatant is poured off. The tube is tapped at the bottom to resuspend the sediment in 0.5 ml of urine, and a drop of this is placed on a glass slide and covered with a cover slip. So here in this picture, you can see that the urine is taken in the test tube, and after centrifuge, the supernatant is discarded, and the remaining sediment is mixed in the 0.5 ml of urine, and 1 drop of it is taken and put in a microscopy and covered with a cover slip and examined in a microscope. So what are the things that you are going to see in a urinary sediment? There can be the things you can see will be cells, casts, crystals, organisms, and sometimes other things like sperm, etc. And the cells include red blood cells, white blood cells, epithelial cells, and oval fat bodies. Cast may be either cellular or non-cellular cast. Crystals may be either normal crystals or abnormal crystals. And some bacteria, some organisms like bacteria, yeast, Trichomonas vaginalis, microfilaria, or eggs of Schistosomia, hematobium, etc. So we are going to look one by one. So the first cell what we are going to look up is the RBCs in urine. RBCs in urine are expressed as number of RBCs per high power field. RBCs are basically small biconcave anucleate cells seen in the RBC with approximately a diameter of 7 micron. And these RBCs may be called as an isomorphic RBC, which is seen in a normal urine. And in hypertonic urine, you may be able to see the crenated RBCs. And in hypotonic urine, you may be able to see a swollen RBCs. And the next type of RBC which you see in a urine microscopy is the dysmorphic RBC, where the size and shape of RBCs may vary. This results from the passage of RBC through a damaged glomeruli. Presence of more than 80% of dysmorphic RBCs is strongly suggestive of a glomerular pathology. So I am not going to more into details with RBCs because a topic on hematuria is coming up. So moving on to the next cell in the urine, which is the WBCs in urine. These WBCs, if you can see the picture, they are spherical, around 10 to 15 micron in size. It is granular in appearance, in which nuclei may be visible. And if it is degenerated, they may be smaller and have fewer granules. And the presence of many white cells in urine is called as a pyuria. Normally, 0 to 2 white cells may be seen per high power field. And coming to other type of white cells, that is a glitter cells. These are seen in hypotonic urine, in which the white cells are swollen, and these granules are highly refractile and show Brownian modes. Such cells are called as the glitter cells, and their large numbers are indicative of injury to the urinary tract. And if pus cells are greater than 10 per high power field, or presence of clumps is suggestive of a urinary tract infection. And the other causes of increased number of white cells include pyelonephritis, tubular interstitial nephritis, renal transplant rejection, etc. So how are we going to differentiate from urine microscopy? In urinary tract infection, usually these following combination are seen. That is the clumps of pus cells or pus cells more than 10 per high power field, bacteria, presence of bacteria, albuminuria, or a positive nitrate test. And in pyelonephritis, if there is the simultaneous presence of white blood cells along with white cell cast, this indicates the presence of renal infection. And if eosinophils is more than 1% of the urinary leukocytes, it is a characteristic feature of acute interstitial nephritis due to drug reaction. These are the small things that we can gather from the white WBCs in urine. Now coming to the next type of cells that is found in the urine, that is the renal tubular epithelial cells. These increased numbers are found in conditions causing tubular damage like acute tubular necrosis, pyelonephritis, viral infection of the kidney, allograft rejection, and salicylate or heavy metal poisoning. Here, the cells are small, almost up to the similar to the size of white blood cells. They are polyhedral, columnar, or oval, and have granular cytoplasm. But a single large refractile eccentric nucleus is often seen. The next type of cells that we see in the urine are the squamous epithelial cells. These squamous epithelial cells usually line the lower urethra and vagina. And the presence of large number of these squamous cells in urine indicates contamination of the urine with vaginal fluid. These are large cells, rectangular in shape and flat with abundant cytoplasm and a small central nucleus. The next type of cell is the transitional epithelial cells. Usually they line the renal pelvis ureters, urinary bladder, and upper urethra. And these cells are large diamond or pear shape. And large number of sheets of these cells are in urine occur after catheterization and also seen in transitional cell carcinoma. Now the next type of cells that is seen is the oval fat bodies. Oval fat bodies are basically degenerated renal tubular epithelial cell filled with highly refracted lipid droplets. Under polarized light, they show a characteristic multi-cross pattern, and they are seen in nephrotic syndrome, in which there is lipiduria. And some other, we have already discussed in some other cells, some other type of cells may be also seen in urine. That is, spermatozoa may be seen in some urine of men. And here is the other type of, that is a telescoped urinary sediment. Usually this term refers to the urinary sediment consisting of RBCs, WBCs, oval fat bodies, and all type of casts in roughly equal proportions. This usually occurs in lupus nephritis, malignant hypertension, rapidly progressive proliferative glomerulonephritis, and diabetic glomerulosclerosis. And these are some photographs of organisms, that is bacteria, yeast, or trichomonas, or egg of schistosome, hematobia, etc. This can also be seen in the urine microscope. So when is significant bacteria is being commented? Significant bacteria exists when there is more than 10⁵ bacterial colony forming units per ml of urine in a clean catch midstream sample. And also if it is more than 10⁴ colony forming units per ml of urine in a catheterized sample, or more than 10⁵ colony forming units per ml of urine in a suprapubic aspiration sample. Now coming to the last two parts of the urine microscopy, but important parts that we all usually got confused. They are the urinary cast and crystals. So initially we are going to see about urinary cast. What are urinary cast? They are basically cylindrical, cigar-shaped microscopic structures that form in the distal renal tubules and collecting ducts. They usually take the shape and diameter of lumen of renal tubules. And these are basically composed of precipitate of a protein that is secreted by the tubules, that is Tam-Horsfall protein. And these are usually indicative of a disease of renal parenchyma. So how are urinary casts formed? Stasis, low pH, and high salt concentration of the filtrate in renal tubules may lead to the degeneration and precipitation of this Tam-Horsfall protein, and which leads to the formation of hyaline cast. Basically, all type of cast are basically hyaline cast. And once hyaline casts are formed, if entrapment of cellular elements into the hyaline matrix, it may lead to the formation of cellular cast. And if the cells within the cellular cast degenerate, and it forms a coarse granular cast. And if this prolonged stay of cast in the tubules will lead to the further degeneration of these casts and will lead to the formation of waxy cast. And if there is broad casts are also seen when there is when the diameter of the distal collecting tube is dilated due to chronic renal failure or some other pathology, some other chronic pathology, the diameter of the cast may be increased. Both the waxy cast and broad cast are indicators of poor prognosis. So these are some of the pictures of the cast which we are showing. In the picture A, what we are seeing is the hyaline cast. That is a typical hyaline cast with both the borders are parallel and a cylindrical top. And once there is the the B is the granular cast, in which there is the granules, the degenerated cellular elements has occurred, and this forms the granular cast. And in the picture C, you can see the waxy cast, which is more opaque, and the edges are serrated, and it is not parallel and all. It is lead to the long-standing degeneration of the hyaline cast, lead to the formation of waxy cast. And the picture D, where you can see is the inside the hyaline cast, you can see small amount of fat droplets, which is called as fatty cast. And in the E, you can see the red blood cells are being formed inside the hyaline matrix, that is the RBC cast. In F, there you can see the WBC, and in G, you can see the epithelial cells in the hyaline matrix of the cast, which forms the which leads to the formation of the cellular cast. And these casts are the only element in the urine sediment that are specifically of renal origin. They can be either cellular or non-cellular. Non-cellular includes hyaline, granular, waxy, or fatty cast. Cellular cast include red blood cells, white blood cells, renal tubular epithelial cells, etc. And these hyaline and granular casts may appear in normal or disease stage, but usually all other casts are seen in kidney diseases. So let's see one by one. And coming to the hyaline cast, usually they are transparent cylindrical by the appearance, and these are seen in acute glomerulonephritis, chronic glomerulonephritis, congestive heart failure, etc. Now the waxy cast, which is due to the prolonged, which are formed due to the prolonged stasis of this cast, which is usually seen in end-stage renal failure, end-stage kidney or chronic renal failure or amyloidosis. And the granular casts are usually seen in tubular damage, chronic glomerulonephritis, or renal failure. And the RBC cast, hyaline or granular cast within the adherent RBCs, are usually seen in conditions that cause hematuria due to renal pathologies, usually. And coming to the WBC cast usually, which we have earlier discussed while seeing the WBC cells. If WBC along with WBC casts are present in the urine microscopy, it usually suggestive of a renal infection, that is acute pyelonephritis, can be also seen in acute glomerulonephritis. And epithelial cell casts are seen in acute tubular necrosis and certain viral diseases or drugs. And in fatty casts, that is usually the cast matrix admixed with fat droplets are seen in nephrotic syndrome. Usually earlier we have seen the oval fat bodies also seen in this nephrotic syndrome with lipiduria. And these broad casts are usually seen in chronic renal failure. And the telescope sediment is usually, which we have discussed earlier, is seen in lupus nephritis, hypersensitivity reactions, subacute bacterial endocarditis. Now coming to the final thing, which are the crystals. Crystals are refracted structures with a definite geometry and the shape due to an orderly three-dimensional arrangement of its atoms and molecules. And amorphous materials or deposit has no definite shape and is commonly seen in the form of granular aggregates or clumps. So as we have discussed earlier, there may be normal crystals and abnormal crystals. Now we are going to see some normal crystals, that is the crystals in acidic urine and their significance. These amorphous urates are a type of crystals which are light red, which are seen as light red amorphous sediment as seen in the picture, and they are seen in normal acidic urine and or in concentrated urine as in fever and dehydration. And some needle-shaped and pigmented crystalline urates are also seen in normal acidic urine. And crystalline uric acid, that is usually seen as yellowish red plates, sheaves, hexagons, or rhomboid shape, are usually seen in normal acidic urine or post-chemotherapy for lymphoma and leukemia. And some colorless, refractive, and envelope-shaped or dumbbell-shaped crystals called calcium oxalate crystals are also seen in normal acidic urine, may be seen in nephrolithiasis or sometimes seen in ethylene glycol poison. And now coming to the crystals which are seen in alkaline urine and their significance. These are the normal crystals. The amorphous phosphate crystals are normally seen in normal alkaline urine. Sometimes crystalline phosphates like triple phosphates may take the shape of a coffin lid or knife rust or fern leaf or star appearance. These are usually seen in normal alkaline urine or struvate stones due to urease protein positive bacteria and urinary tract infection. And calcium carbonate crystals are seen as small and colorless dumbbell or spherical shapes shape, which is also seen in normal alkaline urine, and a yellow thorn apple appearance crystals are basically ammonium biurate crystals. Now coming to some abnormal crystals. These abnormal crystals, some colorless refractive hexagonal plates with unequal sides. These crystals are usually cystine crystals, and which is seen in a condition called cystinuria. And if some crystals are seen as fine needles in sheaves or rosettes, is usually a tyrosine crystal, which is seen in tyrosinuria. So before winding up, let's look at certain urinary diseases and what are abnormalities we can see in our microscopic urine analysis. That is acute glomerulonephritis, where there is gross hematuria and proteinuria. In microscopic urine analysis, usually we can see, we expect to see neutrophils, RBCs and hyaline cast. And in chronic glomerulonephritis, in chronic means it is a long-standing that may lead to the formation of RBCs. Because of hematuria, there will be RBC cast or granular cast due to the degeneration. And may also, you can see due to long-standing waxy cast or hyaline cast may be also seen in chronic glomerulonephritis. And in acute pyelonephritis, as we earlier discussed, numerous neutrophil with leukocyte cast. And in chronic pyelonephritis also, leukocytes and the cast may depend upon the extent of renal damage. And in nephrotic syndrome, usually the fatty cast and oval bodies. We earlier see the oval bodies and fatty cast usually are seen in nephrotic syndrome with lipiduria. Now, before ending up, I will show some two or three slides, and which and can see whether we can identify these things or not. So this is a sample of a 35-year-old female as a part of a routine laboratory examination, and the initial specific gravity is now 1.015. pH is a neutral pH. Ketones, glucose, protein, blood, nitrate, leukocyte, etc. negative. And are you able to identify this arrowed object? This is basically a large cell with a small nucleus, and basically it is a squamous epithelial cells, and it is a normal finding. And its increased number is seen in a not a clean voided specimen. So a contaminated specimen, you can see this squamous epithelial cells. And this is the second question. I think some of you may be able to identify this special type of crystal. You can see from the geometry, it has got a specific geometric shape that will clue as it is a crystal. And as we discussed earlier, it has a hexagonal shape, and most probably hexagonal shaped crystals are usually seen in conditions called as cystinuria, cystine crystals, and it can be seen in conditions called cystinuria. And this is the final sample which we are going to discuss. This is a urine sample from a 20-year-old female with minimal change disease. The golden brown urine color with a specific gravity of 1.025, pH of 7, protein 4+, blood is negative, leukocyte extrace is negative, ketones is negative, nitrate is negative. And are you able to identify the object? Usually from the shape, we may be able to find out that it is a long tubular structure, and usually it may be a cast, and with something something embedded in the this hyaline matrix, and it feels like a minimal change disease. And from that the lip it looks like a fat droplets, and it may be a type of it is a fatty cast, and it is associated with marked proteinuria and nephrotic syndrome. So by this slide, I am ending my presentation. Thank you for the opportunity for giving me a chance to present from all of you. Thank you.
Thank you, Kailas. Thank you, Kailas, for that presentation. Any questions? Shall we take the questions now or after all the talks?
I think we have time. We'll take the questions now. Maybe 3 questions, 3 or 4 questions.
Yeah. Can you can either post in the chat box or you can ask, unmute and ask.
One doubt, Kailas. When you send the urine for investigation, you see in the paper there is written urine routine, that is urine RE and urine ME. What should you select? Which is better?
Oh, it depends on, we cannot say which is better or something like that. this is just took the topic of urine microscopy and discussed in detail. That's all.
No,
Urine routine has physical examination. There are certain chemical dipstick test, etc. has to be. So more information will be available from the urine routine, I think. So,
what are the indications for doing a urine routine or microscopy, whatever it is? So usually when a patient comes with fever, we just tick off a urine routine also. Maybe it's not a typical urinary tract infection also, we just do a routine test of urine. So always I used to have a doubt whether to do a routine examination or a microscopy examination. Finally end up doing routine. Routine they do both, I think, no? Routine?
Yeah, routine includes microscopy also.
Include microscopy. So better to do that. Okay.
Yeah.
So any specific indications for urine routine analysis? Dr. Binu, any idea on that? Can you unmute Jisha, Dr. Binu?
Please unmute, sir.
Yes. Now, the routine evaluation is not done by microscopy as it was shown. It is all automated. So it's like a package. If you ask for a routine, it involves the biochemical examination as well as the urine microscopy. So everything comes together in a packet. But then we have to actually spin the urine and see whether there is a real pathology there if you are looking for a renal disease. So that is what. But generally, when you do a urinary, you are looking at pyuria. Most often,
okay, that's what. Yeah.
So that is what
only
we are looking.
For UTI, we usually check. Is there any other indications, Dr. Vinu? Is there any other indications? Usually, as a GP, when a patient comes with fever, we always check. Otherwise, usually, when the patient is ICU, we check routine. Because from the surgery department, we always get scoldings. Why did you do a routine urine examination? What is the indication? So
I think I will get it out in my talk.
Okay. Any other questions? Any other questions, or we'll go to the next talk?
I think we'll go to the next talk. If anybody has any queries, please post it in the chat box by the time the next talk happens, and we'll discuss at the end again.
Yeah, thank
Over
you.
to you,
Thank
Indu.
you, Dr. Ken. Yeah. The next talk is by Dr. Binu Upendran, Diagnostic Approach to Proteinuria. He's the Chief Nephrologist, Lourdes Hospital, Ernakulam. He has done his MBBS from Government Medical College, Trivandrum, MD from Madras Medical College, Chennai, and DM and DNB Nephrology from Government Medical College, Trivandrum. His areas of interest are renal transplantation and renal physiology. He has been a Secretary of Nephrology Association, Kerala from 2016 to 2018. And he has a lot of publications. And one of his latest is Primary Atlas Syndrome, presenting as Acute Nephritic Syndrome, the Saudi Journal of Kidney Disease. He has also authored a book with Dr. J. Samuel, Urology and Nephrology Text for PG Entrance. And in Lourdes, all of you must be very much acquainted to him. For others, I can tell you, he's a very inspiring and dedicated teacher. And most of the DNBs depend on him for for getting trained in medicine and family medicine and even other subjects. And really, he's a very lovely person, and we would love to hear from you, sir. Over to you, Dr. Binu. Jisha, unmute. Can you unmute?
Okay, can I share my screen?
Yeah, yes, sir. Should I share?
No, I will share it because
you will share. Yeah.
Can I do that?
Yes, sir.
But it is not. It's not coming.
Jisha, anything?
Sir, share, sir.
Okay.
Sir, can you just try once more?
Yes.
Yes, it's coming, sir.
Something went wrong.
Yes, sir. Coming. Yes.
Okay. Oh, I'm extremely honored to be here. Thank you, Dr. Indu, for inviting me, and all the AFPI members for inviting me. And so it's a pleasure to see you, and so excited to see all our past alumni of Lourdes Hospital. Just before I go on, this is what was in my head when I did my MD and passed out of medical college. And needless to say, this is a treatise for children, but then there is a lot of philosophy in it. So this is how it goes. Are you planning to follow a career in magical laws, Ms. Granger? No, I am not, retorted Hermione. I'm hoping to do something good in the world. So that was how it started. After my MD exams, after mugging up all the exotic syndromes, I was posted in a difficult rural area called as Rajakumari. When I landed there, I found out that all the objects could not be reused, could not be repaired. There was an X-ray machine, there was an ECG machine which could not be repaired. I could only salvage these two machines out of from the PHC, and this is what I had after 1 month of my posting there. And by the end of 1 year, when I was there, I acquired this machine so that I could transport patients downhill to a patient where I could treat them. So needless to say, in the 1 year which I spent there, I could manage all kinds of patients. The confidence and the faith which all those people there trusted in me was so much so that I could manage Colles fracture, I could manage acute MI, I could manage even twin pregnancy, deliver twin pregnancies. Of course, I had mishaps as well. So by the time I left Rajakumari, after a year of stint in Rajakumari, I realized that family medicine, or rather general practice, is my pie. And I am so grateful to you. I must say that it was the most treasured years of my professional life. Those 1 year in that village called Rajakumari. I have learned to practice medicine alone, all alone, without anybody's help. In fact, the first day I joined there, it was a camp for copper T insertion. I never knew how to do copper T. But then all the staff there helped me, and we had 30 patients on day 1 to do copper T. And by the time I left, it was so full. And when I left, it was a tearful farewell for me. And the entire village was closed and came to see me off in a bus. So that was 15 years from today. So let us go to the topic. The topic is very interesting, and thanks to Indu Madam for making me relearn this topic. So I will talk about the physiology, what proteinuria testing is, proteinuria values and types of proteinuria, the significance, the presentations, approach, and try to conclude it. So as you know, this is the functional unit of the kidney, and this is how a glomeruli would appear on an electron microscope. And this is the food process which we are all thinking. As of now, when we were students, we were taught that the functional unit of the kidney is nephron. But as years pass by, I have realized that it is in fact the podocyte which is the functional unit of the kidney. So let us go to the normal physiology. The normal urine contains less than 30 milligrams of albumin per day and less than 150 milligrams of protein per day. Dr. Kailash has described the difference between albumin and protein. As he said, the majority of the protein are secreted from the tubules, TAMS, phosphol, protein included. Now, proteins filtered by the glomeruli are normally absorbed by the PCT. And if the excretion exceeds 1000 milligram, it overwhelms the proximal reabsorptive capacity and it spills over into the urine. So that is what normally happens. When you say somebody has got proteinuria, it means it has spilled over beyond what can be reabsorbed. Now, this is the simplest test, heat and acetic acid test. This is what we do. If you look at it, you put a newspaper behind it and just try to read it. That's all. This is what we insist our patients, especially nephrotic children. So this is what we ask the mothers to do. They keep doing it at home and come back and tell me what they are doing. Of course, this is how it is interpreted. We ask them to send a WhatsApp of the picture also. Of late, what is done is a strip test. As you know, the protein, there are several parameters which can be assessed, but then protein is what is the most important thing. So as you see the color coding for different levels of proteinuria. Now, the important question is, what is the difference between proteinuria and albuminuria? As you all know, albumin is a negatively charged molecule. It doesn't filter off soon. So when albumin gets filtered, it means to say that the glomerular podocyte is injured. So proteinuria in urine, as I said earlier, is filtered as well as secreted. Albumin is most often leaked out from the glomeruli. So albuminuria indicates podocyte disease or a diffuse endothelial damage also. So both go interlinked, but then albuminuria seems to be more specific for the podocyte and proteinuria seems to be more specific for the endothelium. Now, what is commonly done across the world is protein creatinine ratio. We should have a clear understanding of what it means. The protein creatinine ratio goes with the premise that every normal individual would excrete 1 gram of protein per day. So if you can estimate the amount of protein per gram of creatinine that is excreted, it is roughly equal to the 24-hour urine protein. That is what we understand when we do a protein creatinine ratio. If you go to the West, it is most often protein creatinine ratio that is done rather than measure a 24-hour urine protein because it is cumbersome. Now, there are several values, as Jitesh should be knowing, that it's expressed as milligram per millimole elsewhere, but we commonly give it as milligram per gram, or gram per gram is what is reported. So if there is a 0.15 milligram per gram of creatinine, PCR is 15 or 0.15, it means 150 milligram of protein is excreted. So this is a spot test. It can be done easily, but then there are errors in it. So that is the problem with protein creatinine ratio. As I said earlier, albuminuria is perhaps a more important estimate of renal disease. For example, in diabetics, we use albuminuria specifically. The reason, as I said, you can pinpoint the lesion to the podocyte. So these are the different levels of albuminuria which are estimated, especially in a diabetic. We'll come to it later. So these are all theoretical aspects about it. There are three types of proteinuria. One is the orthostatic proteinuria, then there is a functional proteinuria and isolated proteinuria. Orthostatic proteinuria is somebody who walks down to the lab, gives the urine for examination. You get proteinuria, you are worried. So orthostatic proteinuria indicates that the patient has walked or jogged to the lab and given the urine sample. Functional proteinuria, you get in various conditions like fever, cardiac failure, and so on. It is a non-renal cause of proteinuria. As previously it was discussed, what is the indication of doing a proteinuria? I think functional proteinuria is an important step because cardiac failure as well as liver failure can produce functional proteinuria. Even febrile episodes can produce proteinuria. More importantly, in a critical ill patient, proteinuria indicates a diffuse endothelial damage. We often see patients with endothelial leak syndrome getting admitted in the ICU. So functional proteinuria is an indicator of the diffuse endothelial dysfunction that this patient has. Then there are isolated proteinuria, which has no reason why, where there are no pathology associated with it. So these are all the different types of proteinuria. Now, how do they present? Nowadays, since it is common knowledge in social media as well as in visual media, everybody comes to the hospital saying that they have frothing of urine, which may be pathological, may not be pathological. They have noted that a dry parchment at the urine site, at the urinated site and so on. They come with high colored urine. They went for routine checkup and found out that there is 1+ proteinuria, or proteinuria was found during evaluation of dysuria or pre-employment checkup. So many reasons why they come up with proteinuria. Now coming to specific situations, for a child, proteinuria of 40 milligram per kilogram per 24 hours. This can be quantified based on the weight. Now, if there is more than 40 milligram per kilogram of proteinuria per 24 hours, it is pathological. It's considered as nephrotic syndrome. So in a less than 9-month-old child, it is considered as a congenital nephrotic syndrome, or it can be a part of TOJ infections as well. Now, there is a gray area where 9 to 2 years old child also present nephrotic syndrome. It could be congenital nephrotic syndrome, but we should biopsy these patients to rule out congenital nephrotic syndrome. Now, the classical nephrotic syndrome occurs in a patient who is between 2 to 12 years. Now, mind you, this is a very common illness. It's reported to be around 5% in the children in the childhood population. So it has to be managed by medicine, family medicine, general practices. All these people get to see them, and it is when the first episode is there, it is managed with 4 weeks of full dose steroids. Subsequently, the episodes are managed with 1 week of steroids and tapered. Now, the response to steroid is the most important predictor of outcome of this group of patients. There is an infrequent relapser who has less than 3 episodes per year, and a frequent relapse who has more than 3 episodes per year. Non-response after 6 weeks is considered as steroid response. So that is about nephrotic syndrome. Acute nephritic syndrome, again, it's little more in an adult child. It is 4 to 12 years. They present with hypertension, fluid overload, low C3, which normalizes after 3 months. So that is the rule in acute nephritic syndrome. We'll come to the pathologies later on, but this is what happens normally. Now, as Dr. Kailash said, these are all RBC dysmorphic RBCs which you see in a glomerular bleed. These are the RBC cast which we had discussed. So when you look at both proteinuria as well as hematuria, they overlap a lot. And as you can see, it comes in minimal change disease, you have isolated proteinuria. And as you go further, when vasculitis or PSGN sets in, it becomes a pathological or a more aggressive form of disease. So that is what urinary examination is all about. In other words, it is called as the liquid biopsy of the kidney, which is already mentioned. Now, be that as may, we will go to some of the cases which I had seen in this in the last 15 years. So there are some laws of medicine. Medicine, unlike physics or mathematics, doesn't go by laws. So the first important fact is that a strong intuition is much more powerful than a weak test. So you can't go by test alone in certain cases. As of now, we get to see COVID patients whose chest X-ray shows very much in favor of COVID, but repeated TrueNATs turn out to be negative. Normals teach us rules, but outliers teach us laws. These are all things which we will learn in our day-to-day practice. And for every perfect medical experiment, there's a perfect bias as well. So these are things which have to be kept in mind. We'll go to a few cases which shocked me and gave me a lot of sleepless nights as well. So this is a case, a 10-year-old child who was nephrotic from the 3rd year. He was one of our staff's child, and he was an initial steroid response. Subsequently, he became steroid resistant. Unfortunately, I couldn't get him for a biopsy. He landed up, I saw a creatinine of 1.4. I wanted to biopsy him, but he kept away. Finally, he landed up with a creatinine of 14. He was put on maintenance hemodialysis and he died at the age of 10 years. It was such a shocking episode. It was one of our staff's child, and I presume it was some type of a congenital nephrotic syndrome which was missed out. So that was case 1. Second is a 17-year-old girl. She was supposed to take exams, CBSE 12th exams next day. She was admitted 1 day prior to the CBSE exam, and the creatinine was found to be 14. When I checked her previous records, it was an acute nephrotic syndrome which occurred at 8 years of age. At that time, she was diagnosed to have a normal C3 and an acute nephrotic syndrome, from which she apparently recovered. So probably it was an IgA which had progressed. The third case was a 21-year-old gentleman. He went for a pre-employment checkup and he was found to have a 2+ proteinuria on pre-employment checkup. He was a hotel management guy, and his 24-hour protein was only 640 milligram. I kept him on follow-up. He came after 6 months. His proteinuria shot up to 1,700 milligram. I did a kidney biopsy. It was IgA nephropathy. He progressed to ESRD by 25th year, and he had to undergo a transplant. So this was probably an IgA nephropathy which progressed despite the treatment which we offered. And case 4 was a primea gravida who was hypertensive at 32 weeks, and she had a proteinuria of 8 grams. She went into renal failure with a creatinine of 1.8. As you know, in pregnancy, more than 0.8 is considered as compromised renal function. Pregnancy was terminated. We did a biopsy. It was MPGN, membranoproliferative glomerulonephritis. She progressed to ESRD in a year's time. In case 5 is a gentleman who was evaluated for edema and tiredness, and his creatinine was 3.2. His Benz-Jones proteins was negative. Sorry for the spelling. Probably it was because of renal failure, it was negative. His proteinuria was 8,500. We did a biopsy, it was AL amyloid, and we did a bone marrow as well as a free light chain. It was a pre-myeloma state or a myelopathy of undetermined significance. So these were the first, 5 difficult cases which I handled. And 6th is a common case which we get to see in and out. This was a 45-year-old gentleman. He has been a diabetic for 10 years. He was meticulous with his blood pressure as well as his diabetes. He lands up with a GP who noted proteinuria of 80 milligram per day. And he was so worried that he came with his entire family members thinking that he had renal disease. So I'm sure all of us will be facing, if you're not faced, will be facing a problem like this. Now, let us see what it is. Now, we have studied persistent microalbuminuria for 10 years. If a patient with persistent microalbuminuria is followed up for 10 years, 40% of them progress to overt microalbuminuria. 40% of them remain the same, and 60% will regress. But 60% will have a major cardiovascular event. That is what happens in a diabetic. Mind you, all diabetics doesn't develop renal failure. A very common question which all diabetics would ask is that, am I going to develop renal failure? But then the fact is that only 30% will go on to develop renal failure due to diabetes. Or the other 60% escapes getting a kidney disease. This is the golden rule. And as a rule, it is said that if you are a diabetic for 20 years, and if you don't get diabetic nephropathy by 20 years, you probably escape from getting diabetic nephropathy because you don't manifest glucose toxicity. So whenever a patient with diabetes comes up and says, will my kidney go off? You can surely reassure them, no, that will not happen. Now, for a non-diabetic, microalbuminuria doesn't mean anything. Only thing we can say that it is a cardiovascular risk factor. As Dr. Indu has asked earlier, whether doing urine routine examination contributes to anything. If there is proteinuria, you can very well say that the person has gotten a diffuse endothelial dysfunction, and probably you have to look at the cardiovascular risk of these patients. So that is what. And now, being a GP, from my 1-year experience in Rajakumari, as I said, the crux of GP is when to refer a patient. If you know when to refer a patient, you are going to be a super hit or a very famous person in that locality. So this is what you have to know. For a child with proteinuria, a child less than 2 years, you refer them for a biopsy. If a nephrotic child comes, as I said, this is around 5% of children. So you are going to see these cases in your lifetime. I'm sure about it. You give them steroids, assess them after 6 weeks. If they respond, you keep them with you. And if they develop steroid resistance, refer them. And proteinuria plus hematuria, you have to be careful. You have to check for C3. If the C3 is not coming back to normal, or C3 is normal throughout, you have to subject them to kidney biopsy or refer to a nephrologist. So that is with regard to a child. For an adult with proteinuria, more than 10 milligram per day with normal renal function, you can wait and see if the proteinuria reduces by controlling hypertension and controlling diet. If it persists for more than 1 gram, you should refer to a nephrologist for a kidney biopsy. And if a person has got a renal dysfunction in addition to proteinuria, subject them to biopsy. Pregnant lady with nephrotic syndrome, not very common, but still it can be a problem later on. You have to terminate and assess the proteinuria. For a diabetic with proteinuria, assess the quantity of proteinuria. Nephrotic range seldom occurs, but do occur. If there is no associated diabetic retinopathy, we have to biopsy these patients. And you have to check for urinary tract infection, sonological evidence for renal ischemia, and so on. And post-void result, they are more prone for urinary tract infection. These are the things which you should look for. And this is the million-dollar question: when to refer? A child who is non-responsive to steroid at any point of time, an adult with proteinuria and hematuria where ultrasound doesn't show any urological abnormality, and worsening of proteinuria on follow-up, or a persistent renal dysfunction, a diabetic with the proteinuria, and of course, the doubting toms, of course, continue to be a problem for the nephrologist as well. So you get rid of them as soon as possible. So let me conclude by what Voltaire said. Doctors are men who prescribe medicines of which they know little, to cure disease of which they know less, and of human beings of whom they know nothing. But I believe that family medicine is otherwise, and you have a lot of opportunity to be the family, to be with the family members. You can take them into confidence, and you can do a long way in managing a family as whole, which is the functional unit of our society. Thank you. Please remember that we are living in a very, very, very important era. We are going to be remembered by the fact that we all survived the corona pandemic. Thank you all.
Thank you so much, sir. It was a wonderful presentation. Now it's open for questions. Dr. Binu, one question from me. My question is about in pregnancy. In PAH, a patient comes with PAH, that is at 20 weeks of pregnancy. What are the tests need to be advised regarding? Do we have to look for proteinuria at that stage? That urine protein creatinine ratio, what all have you to check? And what are the risk factors? What to tell? When to say the patient is safe? Because many times I get a problem in that, because urine protein creatinine ratio is 0.3. So whether we need to intervene at that stage, whether to we need to control the BP, that's okay, but still the proteinuria will be slightly disturbing.
Let me be very honest with you. If you are sure that you are dealing with PIH, you can manage properly. You don't worry about it, because it is related to the pregnancy. So the point is, if you doubt PIH, then you are in a trouble. Now, as you said, if it is after 20 weeks, the occurrence of hypertension is after 20 weeks, you can be fairly sure that you are dealing with PIH. So if it is PIH, everything is pregnancy induced. Once the pregnancy comes off, the lady is fine. But the problem is when you are not sure if it is PH. If it is a pre-existing hypertension or a pre-existing renal disease, it's fine. Now, there is one way to make a diagnosis of PH. The hyperuricemia which you see in these patients are very diagnostic. So look for hyperuricemia. If you see hyperuricemia, you should be happy that you are dealing with PH. And proteinuria can go to the extent of being nephrotic. There are instances where we have transfused albumin and made them euvolemic and continued pregnancy till term. So if you are sure that you are dealing with PH, I think you can be safe about it.
For uric acid levels, any particular levels are there?
5. Uric acid generally in pregnancy, because of the increase in volume, it is 5. Uric acid basically denotes the intravascular volume. So in PH, what happens is the intravascular volume gets depleted. So that is why uric acid goes high. In normal pregnancy, you expect the intravascular volume to increase. And for the same reason, uric acid should have come down. But when there is PAH, the intravascular volume reduces and uric acid increases. So that is an indirect evidence to show that it is. As I said, proteinuria indicates diffuse endothelial dysfunction. So
you need to control the BP only.
Of diffuse endothelial leak, as you see in our critically ill patients, dengue.
So do we have to control the BP only in these patients? Any other precautions should we take?
BP has to be controlled. Then rest and all those, you can't ask them to restrict fluid intake. You can't ask them to restrict salt, but all of them in moderation has to be.
And after delivery, how long should we follow up that?
Generally, in the postpartum period, it regresses. By 42 days, all these things should come down.
Everything has to come to normal.
If it persists after 42 days, then we have to follow them up more aggressively.
If the patient has persistent BP after 42 days, what is the take on that?
There are studies.
There are a lot of patients coming like that. So I feel
there are studies which have shown that these patients are prone to develop essential hypertension later on. So we have to keep them on follow-up. including renal functions and proteinuria. But generally, the proteinuria regresses completely by 2 days.
Any other questions? Anything in the chat box? Regarding frothy urine, I think many young people come telling urine is frothy, and when we see the 24-hour urine, it comes around some little less than 300. So should they be on a follow? Because these people take a lot of protein, go to the gym, they do a lot of exercises, and also
what we generally do is, if the proteinuria is in excess of 500 milligram, we can keep them on follow.
Okay.
You strictly
More than
advise
500.
more
Okay.
than 500. If it is between less than 500, we generally ask them to come for checkup after 1 year or maybe 2 years.
Okay.
We don't ask them to be. But then one must understand that there are several causes for frothing of urine. It is not just
that's okay. Yeah.
It just goes to show that there are some substance which is reducing the surface tension of the water. So it doesn't mean that all frothing are proteinurias.
Okay. We try to make them understand, but still they have a lot of doubts.
It is.
You
have to sit with them. You have to convince them there is no. Especially this microalbuminuria. Every lab does a microalbuminuria, and it is tested, and then they don't know what is to be done. They'll end up with different situations. So microalbuminuria is being used everywhere, abused everywhere.
Then so many doubts are coming. Okay, let me see. Any other questions?
Okay, let me ask one question.
Yeah, yes, sir.
How do you collect?
You're breaking, sir. Your voice is breaking.
What do you advise? Ratio which we do is not. We said that you should do 3 and take the average of it. If you ask them to 3, they come with 3 different values. So I have stopped doing protein creatinine ratios. Now I ask them to get a 24-hour urine protein done properly, collecting the urine. So it is done in a peculiar way. You have to throw away the urine at the point when you are collecting. Suppose if it is 8 a.m., at that point the urine is discarded, and whatever is voided after that, even 1 drop is collected. And at the same time, if it is 8 a.m. today, 8 a.m. is voided. Next morning, 8 a.m. is collected. So it has to be the 24-hour urine that has been excreted, which has to be collected. The collection is the most important part of the test.
So for urine protein creatinine ratio, what did you say? I couldn't hear that.
Urine protein creatinine ratio, generally we get a result as 0.7, 0.75 and so on. So what I generally do is ask them to repeat it. Patient may not be so symptomatic and so on. So I ask them to get it repeated. So when they repeat and come, it comes down to 1.175, 0.15 and so on. So when you repeat, you get different values. What is said about ratio is to do a 3. As I said earlier, to the lab and gets it done, it can be falsely high. So that is one of the problems.
Thank you, Binu sir. No more questions. We'll go to the next talk. Thank you so much, Binu sir, for the wonderful talk. Over to Dr. Rashmi. Dr. Jisha, please unmute Dr. Rashmi.
So for the final talk of the day, another proud moment for me. I'm too excited today. The second talk is also by one of my students, Dr. Jitesh, who did his DNB family medicine from Louth Hospital, and later went on to do MRCP UK from Royal College of Physicians UK, and then SCE in geriatric medicine from Royal College of Physicians UK. While he was at Louth, he has received the best paper presentation at the first Kerala State Family Medicine Conference in 2015, and was part of the quiz team winning the 3rd prize at the Von Casa conference at Chennai. And I think I have not heard from him many talks, and this is a proud moment to hear from him, hear from a student and learn from a student. Over to you, Jitesh.
Hello, guys. So I'm honored to be on this group, and I am thankful towards Indo Madam and Dr. Danya Madam and Rashmi Madam for giving me this opportunity to do this presentation. I have been given the topic of evaluation of hematuria. So just a sec. Yeah. So I'm just going to run through the bare basics of hematuria. In my practice, I usually come across very old people with specific causes, which is mostly due to their anticoagulant therapy or because of the catheter or certain malignancies. But I will try to give a rough idea of how to approach the hematuria which you come across in your day-to-day practice. So coming to the types of hematuria, well, you can broadly classify it as a gross hematuria and microscopic hematuria. Visible gross hematuria obviously means that it is visible to your naked observation, and usually the presenting complaint will be hematuria as far as the patient is concerned. They will be coming to you telling that the urine seems to have some blood in that, or it is off-colored, or it is if it is not normal. And in case of microscopic hematuria, obviously the definition being more than 3 RBCs per hyper field on microscopy. And that would obviously be a finding when you're obviously looking into something. At the outset, I would say that, for gross hematuria, you need to have a very low threshold for referral, because if you're talking about an elderly or someone over the age of 40, there is a chance that it could be a malignancy, and that is something that you wouldn't want to keep with yourself for a long time, and we'll come to that at a later point of time. So again, this is basically an image showing the sources. So when you have blood in your urine, it should come from somewhere in this pathway. So it could be the kidney, the ureter, the urinary bladder, the prostate, or the urethra. So again, as it is shown over here, it could be the glomerular causes, the extraglomerular ureteric. So most often what you would see is the lower urinary tract infection in most of our population. And most of the reasons that you would come across hematuria is probably a urinary tract infection. Then you could probably also see urinary calculus. That is not too uncommon presentation. And then the other one would be from the prostatic infection or benign prostatic hypertrophy, and in rare cases, prostatic cancer as well. In our home setting, I think there is also a chance for bladder infections, and that could also have a presentation in terms of having some element of hematuria. Okay. Then while we look for hematuria, we need to be wary of the mimics, because especially in case of ladies, we need to make sure that the blood sample, the urine sample is not contaminated by the menstrual blood, which often take place. And if you come across someone with a hematuria and the patient is actually during the menstrual cycle, it's well worth trying to have another urine sample just to rule out the possibility of a contamination. And the other mimic is very rarely that you might come across, probably porphyria, which could be a mimic of our hematuria. And the other possibilities are hemoglobinuria or myoglobinuria, because it could either impart a reddish or a brownish discoloration of your urine, and it might seem like a gross hematuria to the visual inspection. And obviously, those sort of pictures you might expect in someone who had a heat stroke or road traffic accidents. In such cases, if it's a crushing, you can expect myoglobinuria. And the other thing which we commonly see back home is beetroot. And coloring pigments which might be in the medicines or in the food items, which might impart a reddish color to the urine, and that is that's especially notable when you start some patients on rifampicin, because we got lots of RNTCP patients back home. And the last one, if you work in health service circumstances, you might come along, might come across this is fictitious, where there might be addition of blood into the urine sample for some other malicious purpose. So that is something that you might need to be worried about as well. So coming to the associated symptoms, and history. So from the timing, when you note the blood in the urine, you might get a rough idea of where the source is. If it is an initial, the beginning part of the urine stream, if you have a hematuria which is followed by a clear urine stream, probably it could be a urethral pathology. And if the anti-urine is having the coloration, then it might be an upper urinary tract infection or a bladder pathology. And if it was terminal, then probably it's a prostatic pathology or a bladder neck pathology. And again, if it is a symptomatic, for example, painful, then it's you might want to look into infection as a cause and calculate and or obstruction or both. And in case of painless hematuria, it could be any number of things. But again, some of the stuff that we might come across is, renal cyst, probably some cases of nephritis, anticoagulants. So that is something that I come across a lot of the times, with, especially with the DOACs and people put on catheter also. Especially if you have someone who's on a DOAC or warfarin, and if you see that this chap is having hematuria, it's well worth being cautious about that, because if the patient is having a prime hematuria, and sometimes he might develop clots in the bladder as well and go in for acute urinary retention. So if anyone is on a DOAC or anticoagulants with hematuria, it's well worth doing an early referral to have a check on the coagulation status and treat accordingly. And there's the other entity called the exercise-induced hematuria. Apparently, after a strenuous exercise, people can have apparent hematuria for no other reasons, and which we generally tend to clear off within a matter of 1 week usually. And the other cause of painless hematuria may be a renal or a bladder tumor. So what do you do in this situation? So as a GP, what we can do is we can obviously do a per abdominal examination. We could look for any palpable renal mass per abdominally. And usually what happens is that in case of a bladder pathology, you are not able to usually palpate anything, but you could palpate for a bladder, which might suggest a urinary retention. The other thing that you could look for is a renal angle tenderness, where you have a pyelonephritis developing. Then usually it's associated with fever as well, but there is something that you could actually have a look at while you're in your clinic. And the other one is the digital rectal examination. But what we need to be careful about over here is that if you're planning to do a PSA, you wouldn't want to be doing a digital rectal examination, before the sample has been drawn, as it might have a bearing on the prostate-specific antigen level. So when you do the digital rectal examination, as you already know, in a malignancy, you might have a hard irregular swelling, and the other one, BPH-benign prostatic hypertrophy, you might have a uniform enlargement of the prostate, and in the prostatitis, you would expect it to be extremely painful for the patient. And there is also scope for doing a vaginal examination in case of ladies. It would be to identify a probable posterior wall bladder tumor, and which is exceedingly rare, but that is one of the things that you might be able to do in your clinics. So workup again. So gross hematuria, again, that is something to be very, very wary about. And I wouldn't personally recommend us dealing with frank hematuria in a primary care setting. Wherever feasible, I would recommend that those patients be referred to be a urology or a nephrology workup. And in case of microscopic hematuria, especially if the 2 samples out of 3 are positive, it is in fact significant microscopic hematuria, and first of all, you would have to rule out the most common cause, urinary tract infection. It is this is after that. If microscopic hematuria, only 1 sample is positive, but you have an age of over 40, and this chap has had occupational exposure to benzene or aromatic amines. There's a history of smoking, pelvic irradiation, or a previous history of gross hematuria. It would be well worth warranted. It would be worth referring this patient urgently to the urologist, because these people are at higher risk of bladder malignancies. And again, with microscopic hematuria, if there is any feature of new renal insufficiency, new hypertension developing, RBC cast, dysmorphic RBC, significant proteinuria, I would refer those patients to someone like Votaire. Okay, and obviously, as in all the other situations, you would go ahead with the normal routine examination. You would have a look at anemia, one that would give you a rough idea of, if you're suspecting something like a malignancy, you could either have anemia. If there's a significant blood loss, that would again show anemia. But in polycythemia, you could see polycythemia in case of a renal cell carcinoma because of erythropoietin secretion. So that would be a pointer. And obviously the inflammatory markers for obviously autoimmune conditions and inflammatory conditions. The midstream urine sample you can send for microscopy as well for culture and sensitivity to prescribe the appropriate antibiotics. You can do, while you're in an outpatient, you can do in a urine dip test, and it will give you some idea about any coexistent proteinuria. So hematuria with proteinuria again would be a red flag, and that would require further, immediate investigation. Again, as previously discussed, the renal functions and the electrolytes have to be looked into. Again, the idea is to look for any deterioration of the renal functions. The other thing that you could look for is a urine cytology for the purpose of screening for urothelial malignancies, which could, which you could probably pick up. And as we previously discussed, you could have a prostate-specific antigen. Though we may not be able to solely rely on it, but again, from a primary care point of view, it would be a definite pointer, and immensely high value would be well worth, or a rising titer would be worth warranted, a follow-up. X-ray KUB may help you find out something like a staghorn calculi, ultrasound of the kidney, urinary bladder could rule out any obstructive pathologies, cysts or lesions. But if possible and the facilities are available, a CT KUB with the abdomen or abdomen non-contrast preferred because we are actually checking for a renal pathology, and we don't want to worsen any renal failure which might occur. And the other one will be, that's for the urologist to be doing the cystoscopy. Obviously, the purpose is to check for any bladder pathologies. They could be, you could take samples from the urothelial malignancy, or if it is a papilloma or leiomyoma, you could differentiate what's happening over there. And you could do an autoimmune screen as well, because as Vinasa said previously, stuff like SLE, autoimmune conditions can be screened as well. So basically, what I would say is that from a primary care point of view, I would recommend sticking to something like this chart. Probably if you have a visible, visible hematuria, even if you are able to exclude a transient urinary tract infection, I think it is well worth having a urology referral and a urology assessment to establish the cause. And if it is a non-visible hematuria, again, the fact that you have already excluded a urinary tract infection, then you would follow the, the flow chart. Then if it is a symptomatic non-visible hematuria, obviously you would check for the blood pressure, estimated creatinine eGFR, and albumin creatinine ratio, protein creatinine ratio. Again, you would be checking for the declining renal function, and then you would progress on to the referral. Again, if the patient is over 40, the threshold should be again a bit lesser. So let's say that the patient is at the age of over 40, and all the renal parameters seems to be normal. Then the patient doesn't have any cause, but needs to be persistently followed up, very, very carefully followed up. But on the other hand, over 40 with any of the abdominal values, urgent nephrology referral to establish the cause, and further treatment should be done. So yeah, that's in a nutshell what I had to say about hematuria in a primary care setting. Thank you.
Dr. Rashmi? Dr. Rashmi, are you there?
I couldn't unmute myself.
Yeah.
Thank you, Jidesh, for that comprehensive overview of hematuria. Any doubts from anyone? I think that was very nicely and very well presented in a systematic manner. So anyone has any doubts? Would you like to add something, Jidesh, regarding what we should be doing in India?
Yeah, in India, as I said, any gross hematuria, that's one thing that I would say. If it is a gross hematuria, it's an alarming symptom for the patient and the family members. So, and obviously, there is, if it is a gross hematuria and you're sure that it is not an infection, obviously there is grounds for concern. Even the chance for finding a malignancy is, I think, some of the estimates say even up to 40%, given the age group is 40 or above. But again, with the gross hematuria, I would say don't take chances. If it is not a urinary tract infection, do a referral. And if it is a microscopic hematuria, again, infection is ruled out with deteriorating renal functions. What are we going to do in a primary care setting? If the renal system shuts down quickly, it's going to end up in a lot of trouble. Once you make the diagnosis, if you have a hematuria with declining renal functions, obviously the kidneys are affected. So it might be a nephritis which needs immediate attention. And obviously you made the preliminary diagnosis, you are referring to the nephrologist, and he knows that it is an emergency, and he will try to stabilize the situation. Once the diagnosis has been established, then ideally the nephrologist would refer the patient back so that the family physician can continue to take forward that care plan, and again then liaise with the nephrologist if and when the time calls for it.
So one thing is what you said, I understood is about the microscopic hematuria is that rule out the infection. That is, if it is not an infection, if it is an infection, okay, fine. If it is not an infection and there is a deteriorating renal function, and what else in the urine routine, as Kailash said, will give you an idea that this is not just an infection.
Proteinuria, obviously. Proteinuria, obviously, we need to look for that.
CAS also, I think, maybe.
Yeah. Cast, if you are looking at a urinary CAS, it will suggest a pathology higher up in the tubules or the glomeruli. So in that cases, again, you would have to be a bit cautious and probably do an early referral.
That's what I understood. So any doubts? Anyone has any doubts?
It's a renal calculi, then it will be a crenated RBC, something like that.
Yes, it could be, but renal calculi usually it's associated with the pain, and
Pain,
then
yeah, symptomatic.
they're passing it.
Can I add?
Yeah, yes, sir.
3 things. One, a painful hematuria and a painless hematuria. So if you have a painful hematuria, it is likely to be a renal stone disease or a urinary tract infection. You can manage accordingly. What we do is, a painful hematuria usually goes to the urologist, and painless hematuria comes to us.
So, yeah.
So that
Even fast also. So this renal papillary necrosis that commonly we see in diabetes, that's also a painful hematuria. Yeah.
Painful, painless is one thing. Second is take a proper history. Very often we have seen patients taking ecosprin, clopidogrel.
Yeah, drug induced. Definitely.
Developing hematuria, getting investigated. They have gone getting investigated also. So that is second thing. And third, there are a group of patients whom whenever you test urine, there will be 2 to 3 RBCs.
2 to 3 RBCs, yes, sir.
So if you try to pursue it, you have a hell of a time. We have done biopsies also, and it was no. We were forced to do biopsy in one such patient, and to say it was normal. So that happens, especially in elderly females, postmenopausal females. There can be 1 or 2 RBCs in urine persisting.
So to summarize, I think for family physicians, the most important thing is seeing the patient as a whole with the history and everything else, then assess the hematuria. Just don't look at the urine routine and treat.
Yeah. One thing I would say is my exam, one of the
I remember the case.
was a patient with hematuria. My exam was in Nagpur Medical College, and actually I done everything, and finally while writing I wrote PR not done. So finally he caught me telling why PR was not done, but I didn't know what to say because my seniors told me, other PGs told me you can write like that. No problem, because there's a language problem and all among. There's a Marathi patient also. You can't just go and do a PR. So I thought, if you ask, I'll tell like that. But now Jitesh told me one thing. PSA cannot be tested. No, once you do a PR, I didn't know if I could say that I would have escaped. But it was a hell. He was a professor from Rohtak Medical College, Haryana. He nearly killed me that day. I was almost in tears for not doing PR. But now I think people have escaped. The exam pattern has changed, no? So that day it was a horrible day for that case. But I had when Jitesh was presenting, I was thinking about all that questions he asked: renal angle, anatomy, blood supply of the kidney, and how will you differentiate based on the levels. So that and all, this is very nice. Questions and all were good, but he tortured me for not doing a PR. Okay, Reshmi, anything else?
Yeah, so I think no further questions. So shall we move on to the vote of thanks, Jisha and Indu?
Yeah, Jisha. Yeah, I think can all of them come on the video because we would like to see all of you. Many of our all our alumni are there and current so many newcomers are there. We would like to see you all. Surya Kurup, the only way we can see you all, no? So why you are all going out of the video, I don't know. Matthew is there.
Matthew has come, sir.
Yeah, we would like to see you all. Begum, yes. Lakshmi, Sarin, Anjana Shashidharan, Nadia, very good. Nice to see you all. Yeah, very good. Excellent. Juberia. Sarin is gone out. Sarin, Nishana. Very nice. Surya, I think Surya has left. Okay, then. I think it's already time. We'll go to the vote of thanks. Go to Jisha.
Okay, hi everyone. Thanks for participating in our CME. I'd like to deliver the vote of thanks today. I'd like to deliver my vote of thanks to Dr. Binu, who's given us wonderful talks that was very enlightening. Dr. Kailash, that talk was really in depth, and Dr. Jitesh also. That all of our speakers have given us a lot to ponder about, and us GPs, I'm sure. I mean, we see at least 1 or 2 urine routines every day, but always see, okay, it's normal. This many thoughts never crosses our mind. I mean, we have to think about it. It's most of the time you see a urine routine, it's a urine routine. What is there to think about? But then after hearing the thoughts, then maybe I have missed something. Next time when I see another urine routine, I'll know something more. So that has been very helpful. So thank you everyone. Thank you Dr. Danya. Thank you Dr. Rindu and Rashmi Madam for coming here and sharing this session. And thank you for all of you who have participated. Few people have left already, I think, but thank you everyone. Thank you Dr. Sarin for hosting the session. And I'd like to thank everyone who has joined us today.
Thank you.
Thank you.
Thank you, sir. Sarin, hi.